All right, today we're going to dive into a pretty rare bone tumor that has a bit of a curious identity crisis. It's called osteoblastoma, and while you might not have heard of it, the way doctors figure it out, well, it tells a really fascinating story about diagnosis. So right off the bat, you get this great nickname, the giant osteoid osteoma. And, that's not just for dramatic effect. It tells us something absolutely crucial, that this tumor is basically the bigger sibling of a much more common benign tumor, the osteoid osteoma. Now, this is where it gets really interesting. If you put a little piece of tissue from both of these tumors under a microscope, guess what? They look identical. The histology, the basic cell structure, it's the same. But, and this is a huge but, for the person who actually has one, it's a totally different story. Which leads us to the million-dollar question. If they look the same on a cellular level, how in the world do doctors make the right call? Well, it turns out the answer isn't found under the microscope. It's found in the patient's own body. This is where doctors basically become detectives. They've got this checklist of 4 key clues they use to tell an osteoblastoma apart from its smaller cousin, looking at everything from its physical traits to the patient's own experience. So this table pretty much lays out the whole diagnostic puzzle for us at a glance. You've got 4 key pieces: the tumor size, where it is in the body, how the bone around it is reacting, and the very specific kind of pain it causes. Let's break each one down. Okay, first clue is the most obvious one, and it's right there in the name. Giant osteoid osteoma isn't a metaphor. An osteoblastoma is, by definition, a bigger tumor. And a lot of the time, that size difference is the very first thing that flags a potential diagnosis. Next up, location, location, location. Osteoblastoma really seems to prefer the spine, specifically what are called the posterior elements. Just think of those as the bony arches that protect your spinal cord. Now, it can pop up in long bones, like your femur or tibia, but its habit of showing up in the spine is a major tell. The third clue is all about what we see on a scan. So think of sclerosis as your body building this defensive wall of dense, hard bone around something it doesn't like. But with an osteoblastoma, that wall is surprisingly thin. Sometimes it's barely there at all. And for a radiologist, that lack of a reaction, that's a huge clue. And finally, we have the most personal clue, and this one comes directly from the patient. Pain is pretty common, sure, but the real key is what doesn't work to fix it. If a patient says, look, I've tried things like ibuprofen, and they aren't touching the pain, well, that's a massive red flag for doctors, pointing them right towards osteoblastoma. So, we've got our clues. Now let's step into the radiologist's shoes for a second. How do all these signs actually translate to what they see on a scan? Radiologists are on the lookout for a specific trifecta of signs. First, what they call an expansile radiolucent area. That's basically a dark spot on the X-ray where the tumor is literally pushing the bone outward from the inside. Second, just like we said, very little hardening or sclerosis around it. And third, it's intracortical, which just means it's sitting right inside the bone's tough outer layer. And while an X-ray might give the first hints, the CT scan is really the gold standard for this diagnosis. Its super detailed 3D images give the surgeons a perfect map of exactly where that tumor is, which is absolutely critical for planning what to do next. Okay, so the diagnosis is confirmed. What now? Well, the good news is, because osteoblastoma is so well defined, the path to treatment is also incredibly clear. For the most part, treatment follows a 2-tiered approach. The standard procedure for most cases is called curettage and bone grafting. It's where surgeons carefully scoop out the tumor and then fill that empty space with new bone material to help it heal. For bigger or more aggressive tumors, they might do what's called an en bloc resection, which means they take out the tumor and a little bit of healthy tissue around it just to be sure they got it all.